Okay, all right. So today we're going to be talking about how to stop, why people want to stop atypical antidepressants. So not SSRIs or SNRIs, the very common, maybe most commonly used classes, but drugs like Trazodone, Mirtazapine, Remeron, and Bupropion, Wellbutrin. So my name is Mark Horowitz. I'm a psychiatric clinician and researcher. I've done a lot of work on how to come off antidepressants. My interest was stimulated by the very difficult time I had coming off Lexapro and actually Remeron. So I'm talking about a drug that's all too well known to me today. And I'll let Emma introduce herself as well. Should I get off my screen?
I'll introduce myself.
Yeah.
Okay, and then we'll reshare the screen. So hi, everyone. My name is Emma. I've been moderating these webinars for the last 2 months, which has been really great. And we call these our Tapering series. And it's a great way for people curious about or considering stopping their antidepressants, or they know someone who might be thinking about it. And it's just more to raise awareness for the risks of doing it incorrectly. Many of the people in the chat and people that tune in have already experienced that once. Some people have already successfully discontinued their medication. Some people are in the middle of tapering, and we're here to kind of facilitate and create that sense of community. I also am really excited for this topic in particular because I had pretty adverse events occur when I was on both Trazodone and Mirtazapine when I was in college, particularly with Mirtazapine. So I'm really excited and interested to hear about other people's experiences. There's unclear determination of, withdrawal burden or the burden perceived with coming off these medications. So I'm really interested to see how it's been for other people. And then for Trazodone as well, the night terrors and swells and kind of what that looked like. Also, I was on Cymbalta, so it was an adjunct to put in the Mirtazapine and Trazodone. So a lot of people have experienced polypharmacy with these psychiatric medications and specifically the atypicals. So I'm really looking forward to hearing what everyone has to say in the chat and also going through this presentation. As always, if you have any questions that you'd like Mark or myself to cover throughout the presentation, just drop them in the chat. I'm going to be keeping track of all of them so that we can add them into the discussion session at the end. Sometimes there's a uniquely particular question that comes up in the middle of the presentation that fits pretty well into the transitions of the content that we're presenting or discussing. And I might interrupt Mark, if he so kindly allows, to just facilitate that conversation. So please be active in the chat, get to know each other. And I'm very excited for how today's conversation will unfold.
Great. Happy to be interrupted. Always. We're going to talk about why do people want to stop antidepressants, what causes withdrawal effects, what is hyperbolic tapering, this jargon phrase, tapering in particular, Trazodone, Mirtazapine, and Bupropion, and then some time for some questions and maybe some answers. So what's the kind of overall context? Why do people want to stop their drugs? You can see that there has been skyrocketing rates of long-term prescribing in America. This graph, I think, ends almost 10 years ago and has just continued to go up and up. So the number of people who are on antidepressants for more than 5 years, I think, is now above 25 million people in America. That's about 1 in 12 of the population. 1 in 6 are on an antidepressant, about half are on them for more than 5 years. Most guidelines say that people should be on antidepressants for about 6 to 12 months. Even those guidelines, there are a lot of question marks around them, but even going by the guidelines themselves, many people are on these drugs for much longer than they should be. Many people are on multiple drugs. We know that these drugs have interaction effects that can cause further issues. A lot of people are put on medication in the context of something going wrong in their lives. Divorce, job loss, death of a loved one, diagnosis of an illness, moving cities, not knowing what to do as a lost young person. And so 6 months, 12 months, 5 years, 10 years down the track, they no longer need medication because they have found a new partner, a new job, adapted to their city, or adapted to the grief of some sort of loss, or have found other ways of coping. So lots of people no longer need medication. A lot of people want to try other things. In England, we have guidelines that say that there are 19 equally effective things for depression as antidepressants. therapy, mindfulness, exercise. I mean, I think these all escape the idea of dealing with the root cause, but even ignoring that. So there's lots of other ways people want to manage these things. And there's a whole series of negative effects, adverse effects from the drugs, including emotional numbing, not feeling your full range of emotions. That affects people's relationships, their sense of self, their enjoyment of life, weight gain, sexual numbing. But we know that can persist even after stopping in some people. Issues with concentration, issues with memory, issues with sleep, nausea, bowel problems. There's a very, very long list of issues that these drugs can cause. And there's also some evidence that they can cause some physical health problems like heart problems, strokes, falls and fractures, especially in older people. So there's a lot of reasons why being on them long term may not be the best decision for everybody. We asked a group of about 1,000 people who were coming off antidepressants, why were they doing it? And these are the answers they gave. Many people wanted to see, could they live without medication? They must have had some suspicion. Could I? Should I? Will I? Wanted to try it out. Many people felt they were dependent on medication because when they tried to stop it, they got withdrawal effects. Many people were concerned about what are the long-term health effects to them. Some people felt well enough, they didn't need the drug anymore. Side effects. Some people felt the drug wasn't at all effective for them. It's true for a lot of people. And then a group of young women were interested in becoming pregnant and were aware that these drugs can increase the risk of abnormalities in their offspring as a reason to come off. When people do decide to come off, they face a big problem, which is in most clinical training in medical school, in psychiatry training, and training for primary care physicians, how to stop the drugs is not a core part of the curriculum. There are lots of lectures on how to start the drugs and very few on how to stop them. And that means that a lot of clinicians are very ill-informed about how to do that. And that has left to a lot of people, I'm sure some of them or many of them are in the audience, or many people in the audience are in the situation, they have been compelled to go to online peer support groups on Facebook or other places to get advice on how to come off their drugs. So a couple of famous examples are Surviving Antidepressants and then Facebook groups like Cymbalta Hurts Worse. And to some degree, it's a little bit absurd that drugs that are prescribed by the medical system, you have to go to a Facebook site to get off, as I did. Quite absurd. How common are withdrawal effects? Which we'll talk about a bit more about what they are, but how common are they? Rule of thumb, about half of people get withdrawal effects when they come off their antidepressants. Not exactly known for how many that's severe or prolonged, but probably up to a quarter, maybe 1 in 7, maybe 1 in 4. But the key point is it matters how long you're on the drug for. And so this graph on the right is showing a very simple study. Other researchers asked people, how long were you on your antidepressant before you stopped? And the top line is, did you get any withdrawal symptoms at all? And the dotted line lower down is, were those symptoms moderately severe or severe? And you can see if you've been on the drugs for a couple of months, most people don't get withdrawal effects. Some people do. And if they do, they're mostly mild. They're not moderate, they're not severe. And this is actually where the drug companies did their research. And that's why they often say withdrawal effects are mild and brief. That's why a lot of people's doctors believe that. It's because a lot of articles, papers were published about this group down here. And of course, half of Americans and other around the world are up this side of the graph. And so the information in guidelines is irrelevant to them because once you've been on the drugs for more than 3 years, about 2/3 of people get withdrawal effects and about half say it's moderately severe or severe. And I'm sure that's where a lot of people, we know that's where a lot of people at Outro are, and I'm sure people in the audience. So withdrawal symptoms, they occur because your brain gets used to the drug. And when you stop it, your brain is crying out for the drug. The symptoms, there's a very, very long list of symptoms. There are at least 80 symptoms that have been recognized because these drugs affect so many different parts of the body, the hormonal system, the nervous system, the gut, you name it. The symptoms can be cognitive, psychological, or physiological. So cognitive means things like concentration problems, memory problems. Psychological problems means things like low mood, anxiety, agitation, crying spells, obsessive thinking, suicidal thoughts and impulses, panic attacks. Almost any mental health symptom you can think of can be caused by withdrawal. And we know that this is because of the withdrawal process itself, because it can be found even in people that have no underlying mental health problem. So when we give antidepressants to people with pain problems or the menopause, or even in healthy volunteers, when they stop the drugs, they report all of these issues. The physiological symptoms, a lot of them are listed on the right-hand side of this slide, which are, they're called more discriminatory symptoms. In other words, they help you to discriminate between, is this a return of anxiety and depression, or is this withdrawal? And things like electric zaps, brain zaps, electric shocks, little shocks people get in their heads, sometimes in their limbs, are clearly nothing to do with anxiety or depression, but are very typical of withdrawal. Akathisia is from a Greek word meaning can't keep still. It's a state of great agitation, terror. Some people are often pacing. This is a very, very horrible consequence of withdrawal that I've had a small taste of. Dizziness, lightheadedness, vomiting, vertigo, nausea, gait and coordination problems, sensitivity to light, sound, noise. All of these things are much more typical of withdrawal than a return of someone's underlying condition. Withdrawal effects can last for some people days after short-term use, some people weeks, but unfortunately for long-term users, sometimes months and years. And I think that makes the big difference. Anyone can handle a few days of being dizzy and having a headache. Not pleasant, but we've all been through it with different illnesses. When it comes to months and years, it becomes a very different story. People lose jobs, people have relationships fall to pieces. It can be completely destabilizing to someone's life.
Ed also mentioned that he was surprised not to see insomnia on the list. And I have to say, particularly with the atypicals, coming off of Trazodone, it was so difficult to sleep for me as well. And I wonder too if it's just more particular for the cases of these atypicals, or if you see that generally across SSRIs and SNRIs as well.
Good question. The reason it's not on the list on the right-hand side is because insomnia can overlap with anxiety and depressive disorders. So it tended to be very prevalent, very common in withdrawal, but a bit harder to distinguish. What we tried to do in this sort of list on the right, which is from a research article we wrote, is to look at things that couldn't be mistaken for a relapse. But you're absolutely right. Insomnia is very common with Trazodone and Mirtazapine. It's also fairly common with other antidepressants. But you're right, Trazodone and Mirtazapine are very sedating, sleep-inducing drugs. And so the opposite of them tends to be insomnia. And you're right, it can be very prolonged and very awful. It can also fool people into thinking, that they need the drug. Without it, they can't sleep because they mistake kind of withdrawal effects for them without the drug rather than them coming off the drug. But yes, that's a good point. The other point, again, that confuses people is in the old textbooks, withdrawal was said to come on within a few days. And it can do that. That's not uncommon. But it can also be delayed in onset. So we know it can come on a few weeks and sometimes even a few months after stopping a drug. And that really confuses doctors and patients because they sort of expect it to come on quickly. We don't know why exactly it happens. I think it's probably because there's a whole lot of downstream effects that take time to accumulate. But I see that a lot in my practice. And sometimes going back on the drug can improve withdrawal effects, especially if you catch it quickly in the first few days or couple of weeks. A few weeks. The longer you wait, the more unpredictable it comes. It can still be helpful, but it's a little bit more unpredictable. So getting to slightly jargonized side of things here, hyperbolic tapering is a neuroscience-based method. Actually, there's increasing research now in actual people designed to minimize withdrawal. And it's sort of become the national standard in the UK, although it's not quite come out into widespread practice yet, but still a lot further ahead than it is in America, I'm afraid. And these are a couple of the papers that I and Brian Shapiro have written about hyperbolic tapering. I'll give you a brief overview of what tapering is, and then I'll talk about what hyperbolic means. This is a cartoon. I won't go into too much detail, but it basically says when you start taking a drug, that's the blue dotted line, it builds up in your blood and brain, and the black line, your brain adapts to the new level. Our bodies follow the law of homeostasis. When it's too hot outside, we sweat. When it's too cold outside, we shiver. If there's a drug that's having a big effect on histamine or serotonin, our body adapts to make that effect less. So we're more in the middle. And so you get into this sort of new stable state when you're on the drug. If you stop the drug abruptly, that means you throw it in the bin, throw it out the window one day. It leaves your body in a few days or a few weeks, depending on how long it takes to leave. What doesn't immediately follow that is how long it takes your brain to get used to the drug. How long it takes your brain to get used to the drug not being there. And we know it can take months or even years as the brain slowly adapts back to the drug not being there. And the difference between what the brain expects and what the drug is giving is what causes withdrawal effects. And so this sort of shaded region is basically withdrawal. And this situation is is the equivalent of jumping off the top of a building. It's the biggest, most marked change that causes the most trouble. Tapering is basically going down by smaller amounts of dose. So this might be jumping down every story of a building. And there's still a lag time, but it's less because there's less of a change. And so there's less withdrawal effects. And even better would be making even tinier changes over a long period of time, giving the brain time to adjust to the new level, and that minimizes withdrawal even further. And that's generally the most sensible way to go about tapering. Oh, I see. Okay. So I will talk a bit about Mirtazapine, or Remeron is the brand name in America, and then I'll use that to explain what hyperbolic tapering is. So I'll just set the scene for Mirtazapine. So Mirtazapine has a slightly more complicated action. It affects histamine, and it affects serotonin and noradrenaline or norepinephrine via an effect on presynaptic autoreceptors. I often feel like this is a bit misleading because this is what textbooks likes to talk about. This is true. This is how the drugs affect the brain. I think if you zoom out and ask, how does Mirtazapine affect depression or anxiety? It's a slightly different story. What we know is there is no real abnormality of serotonin or norepinephrine in depression. If you look at the brains of healthy volunteers and depressed people, there is no difference in their chemistry. And there's been 60 years of research done on that. So this idea that depression or anxiety is caused by a chemical imbalance is now recognized to basically be a little bit of drug company marketing. It was based on some ideas 60 years ago that have not been borne out by research. And so this idea that antidepressants can fix a chemical imbalance is mostly marketing. If you ask people on Mirtazapine, what do they feel? The most common answer they give is tired, emotionally blunted, and a bit sedated. And that's what the drug does, whether that's histamine or serotonin. It might be a combination. It certainly helps people to sleep. People are very much knocked out by it. If you look at depression scores in studies, sleeping better will give you a very big increase, a very big improvement in depression. If you feel, I saw a good comment on Twitter that antidepressants don't generally make you feel better. They make you feel less. And I think that's very accurate. In most studies that people are asked, people report that they feel emotionally restricted. That is, their normal range of emotions from very positive to very negative have been squished into the middle. And if you're very anxious, depressed, or panicked, having the volume turned down from a 10 to a 3 can be a great relief. But it's not the same as having the underlying cause of your depression, reversed chemically or fixed. So just put that note in there. But the risk of withdrawal from Mirtazapine, it hasn't been very well researched, I should say. The SSRIs have been researched much more, but from what we can tell, it's pretty high relative to most antidepressants. One of the harder drugs to come off. Withdrawal symptoms have been reported in many studies, although I can't think of one that's been looked at very carefully in a randomized trial. So yes, it hasn't been formally investigated. So there's a lack of research on this, very unfortunately. The tapering, so I want to talk about what does linear dose reductions mean versus hyperbolic dose reductions. I'll show you that on the next slide with a graph. When we get to it, you'll see that like for many other drugs, it's much easier to come off if you have access to smaller doses than are widely available as tablets or capsules from a pharmacy. And the various options that exist is you can halve or quarter tablets with the tablet cutter to start with. There are tablets that are designed to dissolve in the mouth that can be put in a glass of water to form a suspension, or you can get compounded liquids or compounded capsules from compounded pharmacies. So let me just explain a bit on what linear versus hyperbolic tapering is. I actually got to say, this is a picture from a textbook I wrote called the Mortality Prescribing Guidelines. When I update this in the next edition, the graph there's actually been a study that I hadn't seen before that actually shows that this graph is actually much steeper than this one looks like. So this is actually an underestimation of how hard it is to come off mirtazapine. I'll just tell you what I mean by steepness. So what this is a picture of is basically the imaging of the effect of mirtazapine on people's brains. So they used PET imaging, a special sort of nuclear imaging. People were given different doses of mirtazapine, and they looked at what effect it had on the brain. So on this y-axis, although it's got a very complicated name, you can think about this just as effect on the brain. And the key point is that the relationship between dose of mirtazapine and effect on the brain is not a straight line. Doubling the dose doesn't double the effect. So for example, actually it's off the side of the graph here, but let's think about 30 milligrams. Going from 15 milligrams to 30 doesn't double the effect. You can see it here. It's going to say going from 7.5 to 15 doesn't double the effect. There's a difference, but it's not as big as you would think. And even a tiny dose of, say, 2 milligrams, quarter of the smallest tablet, actually has almost half the effect of 15 milligrams. And actually, when I say that this graph is actually a bit steeper, the updated graph actually goes sort of above here. It's even kind of tighter looking graph. And what that means is, if you look at the sort of dotted lines here, a lot of doctors, well-meaning, the way to come off, say, 15 milligrams of Remeron is to go down to 11.25, sort of maybe halve a 7.5 and put it with another 7.5, then go down to 7.5, then go down to half of that, 3.75, then stop it. And you can see why that sort of makes intuitive sense. You're halving the tablets. It's easy for the doctor to recommend. It's just very hard for the patient, to put it mildly, he says with great bitterness. Going down the first step causes a change in effect on the brain. Some people find that quite unpleasant, but some people find that okay. The next step has an even larger effect. Step again, larger again. And the last one is a really big effect. It can have about 10 times the effect of the first reduction. If you imagine even steeper graph, this is even further exaggerated. And so people say exactly this. The first few milligrams of the reduction were okay, and the last few were brutal. And doctors who are not well informed about this relationship can misinterpret those symptoms and say, look, the person needs the drug, they've got sick again, they need the drug, they can't come off it. A better way to come off it is not to reduce by even amounts of dose, but to reduce by even amounts of effect on the brain. So I've drawn 4 horizontal lines equally separated according to the y-axis, the effect on the brain. And that corresponds to smaller and smaller size dose reductions. And because this shape is called a hyperbola, these doses have been called hyperbolic tapering. And what you can see is you need to go down by smaller and smaller amounts down to very small final doses, sometimes less than 1 milligram. So that final step down doesn't cause a bigger change in effect on the brain than the previous reduction. So you can imagine if you're walking down this graph like a hill, it starts off a bit like a country road, no major problems. Then it goes steeper and steeper until it becomes closer to a steep cliff. And you have to go slower and slower to accommodate that. And that's what hyperbolic tapering involves. And in order to do it, you need to get those smaller doses of drugs using compounded tablets or capsules or liquids. So I'll talk about Trazodone. You'll see there's a bit of overlap. Again, it affects serotonin transporter. A slightly different way to Remeron. Again, when you ask people on these sort of drugs, how do they feel? They say sedated and blunted. So I think there's a lot of in common between these drugs, how they work, despite their slightly different chemical effects. The risk of withdrawal, again, there's not much research on it. So this is referring to a helpline, there was a helpline set up in the 2000s in England that took phone calls about withdrawal effects from these drugs. And this wasn't very common, but also it's not a very commonly used drug anymore. So I'm not sure that this is the best data. So it's not known very well. I've certainly heard from other people that this can be very hard to come off. So I think we don't really have enough information.
Yeah, I know I'm like an N of one here, but
Yeah, chime in.
I know Trazodone was a really tricky one because when you're not sleeping and you're not taking care of yourself, your days start to become so much more painful, and I feel like you become so much more susceptible to environmental changes, mood changes, like social changes, like things can really just affect you. And taking it for sleep and then trying to come off of it, you're, at least for me as well, N of one here, and I'm not a doctor. Sleep just got so much worse that throughout the day, the irritability was really difficult to manage, the stress and like the fear of nighttime and like the stress, the anxiety associated with going to bed made my anxiety and insomnia so much worse than it was before I started Trazodone. So coming off of it, it just felt like it was that plus the withdrawal symptoms, which really made it like a terrorizing experience. So I've also heard that from a couple of people here in the chat. Though we can talk about that more as well here in the discussion.
Yeah, no, thanks for chiming in, Emma. I sort of realize, actually, I'm glad you do that, because I realize that when I give this sort of dry list of symptoms, anxiety, low mood, insomnia, headaches, it sort of sounds like it could be, like a mild hangover or, a cold. I think it's good to hear from a sort of a first person perspective how horrifying it can be. That was certainly my first person perspective as I give this sober lecture. It was the most coming off and completely disorientated me. It completely, I didn't come off as quickly as you did. I'd already learned how to come off in a slow way, but it was still at different points horribly disruptive. Not like when I came off Lexapro where I was thrown into akathisia and real terror, but yes, you're not the first person to tell me how hard it is to come off Trazodone. I suspect actually it's not that different from all the other drugs. There just hasn't been much research on it. So I'm not, I wouldn't sign my name to this idea of low
Yeah.
risk.
I also think another part of it, and correct me if I'm wrong here as well, globally, but in the US, a lot of the time it seems that Trazodone is prescribed as an adjunct medication when people are already on an antidepressant. I know we're not going to be discussing it in detail in today's conversation about whether or not it's considered a first-line antidepressant.
Yeah.
But I do think it's pretty interesting that a lot of my friends, and I've connected with so many people in the space as I was experiencing polypharmacy in school, were on Trazodone but had already been on another antidepressant for at least a year, sometimes, nearing a year on a couple of months. So it might be difficult again to understand the risk of withdrawal at that point too, because you're taking it with your other medication cocktail.
Yeah, that's a good point. I think you're right. Trazodone's not used as much in England, but in America, they use, a lot more drugs. And I think you're right. It's often added on maybe for sleep or something. And because the first drug exactly is giving people insomnia, so they add on a second drug to put you to sleep. So I think that is definitely sort of
And
prescription
then a month later, they'll give you something to help you wake up in the morning. It's
exactly.
just
So
that's the medication cascade for you, everyone.
yeah, exactly. That's right. That is exactly how the prescription cascade works. The side effect of one drug leads to another drug, which leads to another side effect. You're right. It's often followed up with a stimulant like modafinil or Ritalin or these days Vyvanse. So yes, you can turn one drug into three drugs fairly quickly. I'm going to show you that, again, hyperbolic tapering, again, the same principles. And again, the options for tapering off it, you can get a compounded liquid or capsule. You can, to some degree, cut it up into quarters or halves. Especially the IR version is much easier to cut up than ER. And again, so this should look pretty familiar. You can see how actually this one is steeper. Again, very small doses of Trazodone have much larger effects than you would think. So, 20 milligrams of the drug actually has more than half the effect of 150. And again, these sort of linear reductions going down by 150 to 75. What's this? Yes, 150 to 112.5, 75, 37.5. These things sound like they're evenly spread out, but actually they get bigger and bigger. And the last drop is a doozy. That's why people can get into huge, huge trouble with those sort of reductions. And again, it makes much more sense to reduce by even amounts of effect on the brain rather than in terms of dose. And that requires hyperbolically reducing doses down to extremely small final doses where liquids or compounded capsules can come in very handy. And then the last drug. So Bupropion or Wellbutrin, it is quite different from other antidepressants. It doesn't affect serotonin. It affects more norepinephrine and dopamine. It's actually a drug that is extremely similar to an amphetamine. It's got a single side chain that is changed from the amphetamine molecule. And that's what people say it feels like. It feels a bit like taking speed. It gives you energy. It revs you up. If you take it too late at night, it can cause trouble with sleeping. If it has any effect on mood, it's because people get a bit revved up, maybe slightly euphoric, in the same way as if you take an amphetamine. It does, again, there's not much research on withdrawal effects. I have to say, although I think that any antidepressant can give people withdrawal effects, so I'm not saying anything is an easy ride, but it does seem to have less trouble than other antidepressants. So it doesn't mean you can stop it in a day or a week, but it does seem that it's easier to come off than other antidepressants. And again, there's a little research about it. If you do want to taper it, again, there's tablets, which can be halved or quartered, and you can compound liquids or capsules. And you'll probably see the same familiar picture. There's still a hyperbolic relationship between dose and effect on the brain. And so linear reductions probably don't make the most sense. And hyperbolic reductions make more sense, again, going down more carefully at the end, with the overall proviso that it probably is somewhat easier than coming off other antidepressants. And you can use different sort of versions of the IR and slow release drugs in order to make up these smaller doses to start with, and then you probably need to turn to compounded medication. So shall I launch into a few of these?
Yes. Before you do so, I just want to announce to everyone here in the chats, these are some guiding questions. I've also been writing down a few of the questions that you guys have noted in the chat that I have not been able to get back to. There's only so much multitasking I can do at 12:30 in the afternoon on a Thursday. Keep sending in your questions, and even throughout this like FAQ that I put together, and I'll continue adding them to the list, and then we'll walk through a little bit more about why outro and kind of what we do in the states that we're currently supporting in the US. And then we'll have like a free reign discussion session where I'll be pulling questions straight from the chat. So we're good on time here. We'll spend maybe another 10 minutes or so on the FAQs and kind of walk through and get to our end of the discussion so that we can cover everyone's questions.
Yes. Okay. These are interesting questions. Restless leg syndrome can be caused by mirtazapine. Actually, it can be caused by many, many antidepressants. Anything that affects serotonin often can affect muscle movements at nighttime. I've seen a lot of people, I had this as one example. I've seen a lot of people who, this sort of disturbs people's sleep. Some people are not aware of it, they sort of wake up feeling tired. They're not sure why. Sometimes they're sent to a sleep doctor, and they get one of these sort of nighttime polysomnography where they're basically being monitored and videoed, which I've had a interesting experience. And they can see that they're moving around and waking themselves up many times during the night. I've got to say, I think I was woken up between 15 and 20 times an hour, and no wonder I was exhausted in the morning. And so a lot of antidepressants have this risk, and some people end up being given more drugs for this. They get given dopamine agonists, things like Remeron, when a lot of the time the best option would be to slowly reduce the dose of the drug that's causing it rather than add on a second drug. And the second question, why do patients struggle to sleep after stopping mirtazapine, even if they weren't using it as a sleep aid? I think this is a good question because it brings up this sort of topic of, distinguishing withdrawal from a return of a condition. So some people say, I got very depressed after stopping an antidepressant, so I must have depression. I guess it's possible, but if something comes up only when you stop a drug, it's much more likely to be a withdrawal effect than to be some underlying condition. So, for example, we all understand that if you stop smoking and you feel anxious and irritable, it's not because you've sort of revealed your underlying anxiety and irritability syndrome. We all understand it's because withdrawal effects from smoking include anxiety and irritability, because that's all over the TV and bus stops. It's less all over the bus stops and TV about withdrawal from mirtazapine or other antidepressants. But of course, insomnia is a very common withdrawal effect. And so it doesn't matter why you went on the drug, if it was for sleep or depression or some other reason completely, you can still get withdrawal that includes insomnia when you come off the drug, simply because of your brain's chemistry has been rearranged by being on the drug, and it's been, again, sort of disrupted by coming off it, and that's why people can get all sorts of effects, that are across a lot of different drugs. I sort of say, if you hurt your leg, you tend to get redness, swelling, and soreness on walking. And when you hurt your nervous system, you tend to get anxiety, irritability, low mood, headaches, dizziness, trouble sleeping. It almost doesn't matter what the cause of it is, whether it's mirtazapine or another antidepressant. And so that's a kind of a very common final pathway. According to the Maudsley guidelines, mirtazapine led to more helpline calls than most SSRIs. So I think this speaks to that mirtazapine has a very big chance of causing withdrawal effects. And I think it has been understudied in this area. This sort of signal from helplines is an indication that people are having serious trouble. I sort of know that there are a lot of Facebook groups dedicated to different drugs, and one of the larger groups is for mirtazapine, which is a signal that all is not well in people coming off mirtazapine. There's sort of a very hard. People always want to rank which drug is the worst. Mirtazapine may not be the worst drug around, but it's certainly up there in the top group. So it is hard to come off. Is California rocket fuel combination safe? Good question. So Californian rocket fuel, people who don't know, is specifically a combination of Effexor, or venlafaxine, and mirtazapine, or Remeron. It was sort of described by Stephen Stahl, who is a very famous psychiatrist, a lot of contact with drug companies, gets a lot of payments from them. He writes some very famous textbooks that are very famous for their cartoons that explain how the drugs work in a very simplified fashion that doctors like very much. And in Californian rocket fuel, when he describes it as the following. It's the same as putting the pedal to the metal in a car and also cutting the brakes. And what he's describing there is, if you take an antidepressant like Effexor, it blocks serotonin and norepinephrine transporters, which leads to a surge of serotonin and norepinephrine in the brain, in the synapse. And at the same time, mirtazapine blocks the signal that puts the brake on serotonin and norepinephrine. It's a different part of the system. And so he's saying you get your car going really fast by both putting on the accelerator and cutting the brakes. Now, that might sound dangerous if you're talking about your brain, which is a very sensitive organ. And I think this is where it's sort of important to think about what are these drugs doing to the brain, because there's a lot of messaging about these drugs normalize chemical levels in the brain. There's low serotonin, we think, people say, in depression, and giving one of these drugs increases serotonin back to normal levels. It's a very reassuring story because if you've got abnormally low levels, then increasing them back to normal sounds perfectly sensible. If someone told me I've got low thyroid hormone, why don't you take some more thyroid hormone? That sounds like a very sensible move to me. I would say yes to that. But when you understand that there is no low serotonin found in depression, there's just normal levels as is for everyone else, then if you take a drug that increases serotonin and noradrenaline, and maybe does it double or triple fold with this sort of combination, then what you're creating is abnormally high levels of these neurotransmitters in the brain. And the brain is a very sensitive system. So people have said, and made the comparison, that the most similar thing to Californian rocket fuel is taking ecstasy, MDMA. I'm going to say I was on a version of Californian rocket fuel, and I had pupils as big as my eyes, and I was as close to being manic as I've ever been in my life. So, I think Californian rocket fuel is about as safe as what you're being given at a nightclub for most people. And because the levels are so high of these transmitters in the brain, it's going to cause incredible withdrawal effect when you come off it, because it's had you've driven that car without brakes, right into the brain. And so to get that car out is going to be a hell of a hard work. So I think that it has a lot of side effects being on such a combination, and very hard to come off. And I've already said this, yes, Wellbutrin or Bupropion is very, very similar to an amphetamine than to an SSRI. That's probably why it has slightly different subjective effects when people take it. And it's also probably why it's a bit easier to come off than other drugs. So should I go through the last couple of slides, then we do some more questions from the audience, or?
Let's go through the rest of the slides and we'll pick up the discussion at the end. Right now, there's a great conversation happening in the chat. I'm so delighted that people find solace and community and can be vulnerable with each other here. So let's work through the rest of outro and then we'll hit the discussion section.
So I just want to talk for a couple of minutes about what we do at outro. I guess we set up outro in order to plug that hole in the medical system. The medical system is very good at prescribing these drugs. It's not very good at stopping the drugs. When I had to go to a peer support site to find out how to come off my drug, despite all my years of training in medicine and psychiatry, I thought, this is a bit mad. And so I've helped people to set up outro, which essentially implements hyperbolic tapering in a personalized way for people who want to come off antidepressants. You see clinicians regularly. You can message them in between in case things come up with withdrawal effects. We have a group of compounding pharmacists we work with to get smaller doses when it's needed, and a whole host of non-medication supports available for people. And so I guess what it looks like is there's a series of questions to screen for eligibility to make sure that we can help you with a digital clinic. You see a nurse practitioner who looks more closely into your mental health history, the trouble you've had coming off the drug in the past, what your aims are, what you're keen to achieve. We work out a personalized taper plan based on the hyperbolic principles that I've outlined and some of your risk factors, how long you've been on the drug, dose, different types of drugs. And then people are followed up sometimes every week, every 4 weeks, depending on the difficulties they're having. And dose reductions are there and then monitored and carefully supported throughout. I do think the monitoring is very important. That if things go wrong, you can intervene very quickly rather than let things get out of control. You can see a few of the people that are involved in it. A very lovely lead nurse practitioner, Charlotte Herring, Adele Framer, who ran Surviving Antidepressants for many years, various other people that we work with, psychiatrists and patients like Brooks here. We are open in 7 states. Emma will chime in when I get my geography wrong. There's California, there's New York, there's Washington State, there's Texas.
Tell me when you want help.
I'm out. I'm done. I'm tapping out.
Colorado and Florida.
Colorado.
So just one more time to repeat. Washington, California, Colorado, Texas, Florida, New York.
Okay, 6. I said 7, but there's 6. And so if you want to learn more about that, there's a QR code, or there's our website, Outro Health. And I'm happy to take any questions.
So answering questions in the chat. Okay. So Annette, I just responded to you. Annette asked, is it possible to get all the way off medication if medicated as a child before the brain was developed? Mark, correct me if I'm wrong here. I answered yes. I've also spoken to a lot of people that have successfully tapered off medication. And in the Cymbalta webinar on our YouTube channel, Brian actually talks about his personal experience being prescribed antidepressants early into his youth to manage OCD and what the tapering experience was like for him.
Yeah.
Off of Paxil and Cymbalta.
Right. I mean, yes, I think I agree with your answer, Emma. It is yes. I have seen people who were medicated, before puberty or not that long afterwards, that were on the drugs for 20, 30, 40. I mean, I've seen people who have been on drugs for 50 years. I don't know that it makes a big difference if you're on it before or after puberty. I think the time you're on it makes a big difference. So I'm not going to pretend like it's going to be easy. I think if you've been on drugs for a long period of time, it is harder to come off. Is it impossible? I don't think so. To me, I'll tell you the analogy that I use. I think coming off drugs is a lot like altitude sickness. It's not altitude sickness, you go up a mountain too quickly, you get, horrible sickness, headache, dizziness, blah, blah, blah. It's not how high you go up, it's how quickly you do it. So if you go from sea level to the top of Everest in 2 days, guaranteed you'll be as you've ever been. If you go from sea level to the top of Everest in 2 years, it's very hard to get unwell. And the same as coming off antidepressants. If you do it in 4 weeks, guaranteed, for most people, you'll be as sick as a dog. If you do it in 4 years or 2 years, or take your time at a rate you can tolerate, it's a very different story. So I think it's possible for everybody. It's just about the rate. There's the occasional exception, but basically the slower you go, the easier it is.
I could not agree more. So Katie actually reposted in the chat because I wrote this question down anyways to talk to you about. Okay, cool. Katie actually asked in the chat about any knowledge that you might have about the benefits of using probiotics while you're tapering off medication. This actually come up quite a bit also in discovery calls that I've had with potential patients as well. And she said that it wasn't something that she saw in the MODS-ID prescribing guidelines. She'd like to see if you had any opinion on the supplementation of pro and prebiotics.
Yeah. I mean, I guess there's no research to look at these things, so it's very hard to give a definitive answer. I know lots of people do take different supplements like prebiotics or fish oil or multivitamins. I'm sort of aware that there's general health benefits potentially to these things. I don't think there's any harm in it. As it happens, I take a prebiotic. I'm swimming in the same soup as the rest of the world. Does it make a huge difference for withdrawal? I've never heard that, but also it's hard to tell. If something makes something 5% better, it's probably a bit hard to tell. There's actually a colleague of mine who's a psychiatrist and a researcher into the microbiome who wants to kind of look at this sort of issue. She wants to take poo samples from people in my clinic to see she knows that being on antidepressants definitely does affect your gut microbiome. She wants to look at, does coming off it have an effect? And then this sort of idea very much fits in. So the answer is I'm not sure. I don't think there's any real harm from taking a prebiotic. So you might want to try it. No one's ever come to me and said, this has been a complete game changer, but maybe for some people it is.
Joey in the chat asked, can these drugs cause permanent brain damage coming off of them, or do you find that over time most people return to a pre-drug quality of life or maybe return back to baseline? Before you answer, I also just want to mention, I feel like there's a reoccurring theme in a lot of the questions that we've received in the chat today that have to do more with how quickly are you stopping the medication, has a pretty significant effect on what your life and quality of life could be like after the fact. And I'm sure Mark was going to expand on that, but I just really want to emphasize that it's almost like Mark has a great analogy that we're at the bottom of the cliff yelling up to people at the top of the cliff before they jump, not to jump and to do it slowly and to almost like, ballet rock climb down, because once you jump, those are the lasting impacts. Those are the long-term consequences. And that can be what's really difficult and take a long time for people to recover from. But if you do it safely and you do it slowly, there's a whole community of people that have successfully returned back to baseline of this pre-drug quality of life because they did so coming off the medication as slow as possible. Mark, if you want to expand on that.
Yeah. So I'm just flicking through the questions. I think what Emma said there actually answers a lot of questions. I can see people are saying to me, 5 years being, goddamn sick. Oh my God, I can't do that. This is great. I think that you think the altitude sickness is a very good analogy. Yes, it might take you 2 years to go from sea level to the top of Everest, but you're not going to be horribly sick for 2 years. You're going to be feeling fine for 2 years. So, the slower you go off these drugs, the less trouble it causes. Nothing is completely guaranteed, but that's the general rule. I mean, I've seen that now with thousands of people. If you go off it very quickly, the slower you go, the better it is. And also, the less the consequences at the end. So the person has asked, do these drugs cause permanent brain damage?
Uh-huh.
There's a lot of uncertainty here. I think that there is basically two types of issues these drugs cause. There's the issues that you get from being on the drugs, exposure. And then I think there's the issues you get from coming off the drugs. And those can cause, I think those are both of concern. The people that I see that have these issues for long-term afterwards, what I call protracted withdrawal or withdrawal injury, or now antidepressant-induced neural dysfunction, these sort of terms, are people that tend to have come off their drugs very quickly. Not always, but that's generally the rule. And people that come off more slowly tend to have less residual effects, maybe not none. When I think about protracted withdrawal, which people may be aware is this sort of withdrawal, people sort of think about it as a few days or weeks of symptoms. Protracted withdrawal is when it lasts for more than 6 weeks, but often it can be months or years. And I think of that as really, it's something has happened to the nervous system, and I think about it as an injury to the nervous system. I use the word injury because I think injury implies things get better, which is what I mostly see. People get better over time. It can take a long time. Some people use the word damage, which sounds much more permanent, which I think is generally not accurate for most people. I guess, as Emma said about me being at the bottom of the cliff or all of us screaming out, I'd say that the way to avoid all this is to come off it slowly. If you're already in that position, I'm sorry to hear that. That's true of many people, unfortunately. I don't think most things are permanent. I think things get better over time. It's just that the timeline can be excruciating, months or more than a year, and that can very much demoralize people. But I see people who...
Demoralizing is such a good word for that as well, because I think a lot of people can come to and say, well, even what Liz mentioned in the chat just now, I've been tapering for 4 years. I think I'll need another 4 years. Should I really be taking another 4 years? That's another 4 years on medication. Should I really be doing that?
So I guess the issue is, comes up all the time, you're balancing two harms here with these drugs. You're balancing the harm of being on the drug with the harm of coming off it too quickly. If it was just the harm of being on the drug, you'd just stop the drug, no issue. If it was just the harm of withdrawal, you just would stay on the drug, so you wouldn't avoid withdrawal, no issue. But because there's both, you've got to balance those things. And often the best balance is to come off them slowly. And you got to sort of steer between the poles of these two. There's a rock and a hard place. You might be able to do it quicker than 4 years. If it takes you 4 years, it takes you 4 years. The other thing is, if you're on it for 4 years, I assume you'll be on very low doses. So it's not like you're going to be on a full dose for 4 years. You're going to be on, I imagine, 1/20th of the dose or less for that time. So you are reducing your exposure while you're coming off the drugs. Again, it's just about finding this balance. The balance is different for everybody, but yes, there is some kind of playoff between those two things.
And Mark, we cover this in probably every webinar. Can you explain to the audience here what reinstatement is and why reinstatement is suggested to patients at times that are tapering off their medication?
So I'll try to do it in a couple of minutes. Actually, reinstatement is when you come off a drug and you restart it. And if you do that after, if you go away on holiday and you forget your drugs and you get a bit of withdrawal and you come back to your house and you take your drugs again, withdrawal generally goes away 99% of the time in a few days. And so if you come off your drugs too quickly, reinstatement is often the best strategy. When people come to me and they say, I've just come off my, whatever it is, Trazodone, Desyrel, I'm in a complete state, and I came off it a couple of weeks ago, I say, go back on the drug. The longer you wait after you come off, the slightly trickier it becomes, the more unpredictable it is. And so the longer people are off, the more I would suggest trying a test dose. I've taken this from Adele Framer from Surviving Antidepressants. Tried something like 5% of their dose. If they're on 15 of Mirtazapine, I would try 0.5 milligram just to dip your toe in the water to see what it feels like before jumping in the deep end. Just because sometimes the longer you wait, it can be unpredictable. People can have no response to going back on the drug. Some people can even get worse. They call a paradoxical reaction. And so I sort of want to know what is someone's response before they ramp the dose up. And so that's why, people are waiting a few months. I would certainly recommend this sort of tiny dose. Whereas if they're closer to when they came off, a bigger dose and see how they respond. And sometimes it can be quite successful and other times a bit trickier.
And we are at time. So I want to thank everyone for writing all of these wonderful questions in the chat. I actually copied them over. So something that we're going to be doing in the next couple of months is like a broader Q&A session. And it'd be great to hear what type of content you would find helpful for us to be revisiting. This was such a productive webinar and discussion session, and I can't thank you all enough for your participation and connecting with one another with your wonderful recommendations. So on that note, we're going to close off for the day. So thank you so much, Mark, for tuning in with us, and thank you to all of our audience members. And I hope to hear from you guys soon.